Hello, everybody. This is Dr. Jayanth Krishna. So I'm a consultant pediatric neurologist and a clinical geneticist at KIMS Cuddles. So today, I think we'll be discussing about the other aspects of dengue fever. That is the more serious health problem. That is dengue encephalitis and ANEC. So ANEC is basically acute necrotizing encephalopathy of childhood. The agenda of this talk would be quick stats and epidemics of dengue encephalitis, the diagnostic criteria of dengue encephalitis and ANE. That is, we'll be looking at clinical and radiological aspects, and the ANE variants and the concept of DANE. I'll introduce you the concept of DANE. That is, DANE is an upcoming term which is called dengue associated ANE, and also various strategies in management of dengue encephalitis and ANE. Quickly into the incidence of dengue encephalitis, if you see, there's data coming from NIH and WHO which clearly says that there's a tenfold raise in the incidence of dengue in the last decade. And if you see, India is amongst the top transmission of these viruses, especially Zika, chikungunya, and dengue. So very rampant in these Asian countries, including Africa and India. So we have high incidence of dengue here when compared to the Western world. If you see the global data, the incidence of dengue encephalitis in dengue fever is around 0.5 to 6.2. When data coming from India actually state that this can range from somewhere from 4 to 21%. 21% is pretty high. But if you see on average, the global data says that 5% of dengue fever patients will develop some neurological complications overall. So there's another study coming up from the northern part of tertiary India, tertiary center, which actually says that the incidence can rise up to 20%, which is pretty high. And also CDC comes up with another data saying that case fatality rate in dengue encephalitis is almost like 33%. So why is it so important to know about the critical concepts of what is exactly dengue encephalitis and what is exactly the dengue-induced inflammatory syndromes? So obviously we'll look into this. One is to differentiate dengue infection per se versus ITES. ITES is a newer term which is coming the last couple of years, which is infection-triggered encephalopathy syndrome. So previously we used to call this para-infectious diseases. Why is it so important? Again, prompt identification of ITS is extremely important because the major treatment implications are depending on that. Because in dengue encephalitis per se or the infection itself, we don't give steroids or immunomodulation. But in an ITS, we do give immunomodulation. That's the mainstay. And especially devastating ITS, especially ANE needs timely diagnosis. Neuroimaging needs to be done ASAP, and prompt immunomodulation needs to be started in ANE cases. So this is one of those neurological conditions apart from stroke where time is extremely important. Every second counts. Time is brain. Quickly about the virus itself, you all know that dengue virus belongs to this family called flaviviruses. Why is it so important to know about this? They're very structurally similar. I mean, all the other viruses, they have structural similarities, and also a lot of pathogenesis is pretty similar to dengue virus. So why am I talking about this? Because they can have a similar MRI picture. If you see, Japanese encephalitis is a very close MRI mimic of dengue encephalitis. They have bilateral thalamic involvement. So any thalamic involvement doesn't necessarily mean that it is dengue. You have to look at close differentials like other flaviviruses. The same MRI picture can also be seen in West Nile and also other variants of dengue and also few cases of yellow fever viruses. So just remember that flaviviruses love thalami, they're thalamotropic. And why specifically thalamus is involvement? There's a hypothesis which says that thalamus is one of the circumventricular organs, that is CVO, wherein what is CVO is basically these are the structures like thalamus and hypothalamus which are not completely covered by blood-brain barrier. They're bathed in the CSF. So whenever there's an infection of the viremia in the system, it can easily spill into the central nervous system. So that is the reason there's a first contact of these viruses to thalami. So whenever, remember, bilateral thalamic involvement, not just dengue, think about other flaviviruses as well. Coming to the diagnostic criteria of dengue encephalitis itself, it was put forth by Fong et al. In 2022. You need to have fever, very simple one, fever with acute encephalopathy. Acute encephalopathy can in the form of seizures, altered consciousness, or focal signs, with some evidence of dengue infection that can be in the form of reactive IgM antibody or a PCR test being positive in serum or CSF. And then the fourth criteria is extremely important, exclusion of other infectious diseases, which are pretty similar. So this is them talking about other infections, including other flavivirus infections like, West Nile or Japanese encephalitis, which can closely mimic dengue encephalitis. Looking into this study, it is a very systematically reviewed multicentric study done across 4 major centers across the globe, including United Kingdom, Hyderabad, Jaipur, and Singapore. So this study actually has put forth that amongst the case of dengue encephalitis, dengue-induced ANE is the most common, accounting for almost 40% of cases, followed by acute encephalitis with no specific feature. The third one will be ADEM, 15%, and other encephalitis syndromes. We'll look into these in the coming slides. The whole spectrum is ANE, ADEM, acute encephalitis with normal imaging. This could be non-lesional encephalitis. Sometimes MRI and CT can be normal with a lot of CNS manifestations. Then you have miscellaneous encephalitis syndromes. This can be in the form of AEST, acute fulminant cerebral edema, hemiconvulsion hemiplegic epilepsy syndrome, mild encephalopathy, reversible splenic lesion, and acute cereballitis. We'll look into these images quickly. The first case is a very typical bilateral thalamic involvement. Is a case of ANE secondary to dengue. This is a case of ADEM. We have fluffy shadows asymmetric in the corticomedullary junction. You have a very typical ADEM. And then you have a very devastating image. It's called, acute encephalopathy with biphasic seizures and late diffusion restriction. Another similar condition, which is called ALERT, that is acute leukoencephalopathy with restricted diffusion. A common entity following viral infection. This is where you see the restricted diffusion in the splenium. This is called mild encephalitis with restricted diffusion of splenium. And you can sometimes have longitudinally extensive transverse myelitis. You see on the image in the spinal MRI, suggestive of transverse myelitis. This is a case of CT showing dengue-induced acute fulminant cerebral edema. And finally, unilateral cerebellar involvement, hyperintensity, which is suggestive of acute cereballitis following. So all these infections can be, all these inflammatory conditions can be followed with dengue. This is the whole spectrum. So this comes under the category of infection-triggered encephalopathy syndrome. So quickly that was about the acute dengue encephalitis. When coming to acute necrotizing encephalitis or encephalopathy, that is ANE. Quick statistics about this. If you see CDC and NIH comes with the data saying that 5% of any acute encephalopathy patients eventually have the diagnosis of ANE globally. But if you see the incidence is quite high in Asian countries, maybe it's because of the spectrum of infections. Also, they have some genetic predisposition for ANE. You all know that ANE is a bad entity because the mortality rate is almost 30 to 50% despite the right management. And the morbidity is unfortunately and sadly almost 80 to 90%. Only 10 to 20% of patients with ANE walk out of the ICU with no neurological sequelae. Quickly about the pathogenesis, you all know that ANE is preceded by a viral prodrome. We'll look into the viruses which cause that. Then you have a systemic viremia which is happening along with the cytokine mediated damage to various organs. Then you have fever, a lot of inflammation happening in the system. And eventually this inflammatory mediators will cause disruption of the blood-brain barrier. Then you have the cytokine spilling into the brain. So then you have cytokine storm in the brain, predominantly persuaded by IL-6 and TNF alpha. So these are the major players, and you have damage to astrocytes, demyelination, oligodendrocytes, and also microglia. So you have a whole lot of damage happening in the brain because of cytokine storm, the predominant mediator being IL-6. So what are the viruses which are common known to cause ANE? These are the big six, very important to remember because influenza A, B, herpes HHV6 is the same virus which causes febrile seizures. You have enteroviruses, like including Coxsackie and ecoviruses, SARS-CoV during the COVID pandemic, and also dengue in Asian countries, and especially India. And less common organisms include Mycoplasma, Varicella zoster, HSV1 and 2, rotaviruses, chikungunya, and pneumococcus. Why is it so important to chase the organism in a case of ANE, though it's an inflammatory or immune-mediated condition? Sometimes the infection ends and the inflammation starts. Sometimes you can have a residual infection which is going on. So it's very important to chase the organism because there can be treatment implications. Because influenza A and B, we need to give oseltamivir. With dengue, nothing specific. Again, with Mycoplasma, you can have therapeutic targets like doxycycline, azithromycin. With Varicella zoster, herpes simplex 1 and 2, you have therapeutic targets like acyclovir. With pneumococcus, you need to add of ceftriaxone and vancomycin. So this is another study, a Western study, where you see COVID was one of the major causes of ANE, but dengue is not included in this. For some reason, Asian countries have higher incidence of ANE followed by dengue in Asian countries, especially in India. So what is the diagnostic criteria? The diagnostic criteria is put forth by Mitsubishi criteria in 1997. You have major criteria 3. Major criteria is very simple. Acute encephalopathy, that can be in the form of rapid deterioration of sensorium, often preceded by a viral prodrome, with typical neurological MRI features, neuroradiological features, which can include CT or MRI suggesting of bilateral symmetric thalamic involvement, along with white matter involvement, brainstem, putamen, and cerebellum. Here you see the mandatory feature is thalamic involvement. And the third criteria would be exclusion of mimics. We look into the what mimics am I talking about. I think this is beyond the spectrum of this talk. We have many conditions which can mimic dengue encephalitis or ANE. Will not go into the details. And the minor criteria would include CSF findings like you should not have pleocytosis. So the cell count should be less than 8 because we know that it's an inflammatory condition. There's an exception for this. The protein may be elevated or normal. You have elevated transaminases and normal serum ammonia. This is again to rule out other inborn metabolism which have bilateral thalamic involvement. Sometimes organic acidemias, mitochondrial cytopathies, Ray's syndrome can have high serum ammonia and can mimic this presentation. So you need to have 3 major, all major should be present mandatory, plus 2 minor need to be present to call ANE. So this is a shorter version of ANE criteria. These are typical radiological findings. Quickly going into you have T2 and FLAIR imaging showing bilateral thalamic swelling, very clear hyperintensity, swollen thalami. Sometimes you have putamen involvement along with diffusion restriction with a clear rim of hyperintensity. On ADC, you have the classical sign, which is called trilaminar sign with central necrosis surrounded by cytotoxic edema, surrounded by vasogenic edema. This is the typical ADC image showing trilaminar sign in sporadic ANE. This is an SW image showing bilateral bleeds into the hemorrhage into the thalami. And this is diffusion restriction to the medial temporal lobe and brainstem changes. And often remember, along with thalamus, you have white matter changes. You have temporal lobe involvement, you have brainstem involvement, and also dentate nucleus. So this question comes when my center does not have MRI in-house, or I need to shift a child who is hemodynamically unstable to another center just to get an MRI, or do I have to just get a CT to start treatment with steroids? I think you can get a CT, but the sensitivity is a little different. MRI has a clear-cut picture of the ANE. In the CT, you see there is hypodensities in the thalamic region. So you have swollen thalami, which are looking hypodense, and also changes in the brainstem and dentate nucleus can be seen on CT as well. This is a mimic of ANE, which is called Leigh syndrome or Leigh spectrum mitochondrial cytopathy. So you need to rule out mimics like these. So quickly coming into what exactly trilaminar sign is, basically it has central hemorrhagic necrosis surrounded by cytotoxic edema and surrounded by vasogenic edema. So the trilaminar sign is typically seen on ADC sequence. It's very classical of the classical ANE or sporadic ANE. We'll also look into other types of ANE. Whereas if you see double donut sign is basically not 3 rings, you have central hemorrhagic necrosis surrounded by cytotoxic and vasogenic edema. This is a typical image which is seen in dengue-induced ANE. In the classical ANE with other viruses, there is trilaminar sign, but double donut sign is more classical in a case of dengue-induced ANE, wherein it can be seen in T2 and FLAIR images. All right. So quickly coming into clinical manifestations, you all know that there is thalamic involvement, which causes predominant movement disorder and dystonia and status dystonicus. White matter involvement and cortical involvement will cause a lot of spasticity and seizures. You have brainstem involvement early on. Because of that, you have very poor sensorium because the reticular activating system is involved, and you have poor respiratory drive and early mechanical ventilation needing. And sometimes you can also have cerebellar involvement. So this is the explanation of how the child can present to you clinically. And this entity needs to be discussed separately. DANE is a newer entity and a newer term which is popping up recent articles. So DANE is basically dengue associated ANE. Why is it? Why does this need a special description? Because there's a confusion whether it's a direct encephalitis or it is an immune-mediated ANE or it's a continuation of an infection in an immune system. So this is the most accepted hypothesis. It is now considered as an infection-immune continuum. What I mean that is basically the infection is still there and the inflammatory process has already started. So both of them are happening simultaneously. So that was a research question wherein it was questioned by this study which was done by Dr. Lokesh and other scientists. So here they had a question whether it's a variant or is a mimic of DANE. DANE is a mimic of ANA. So finally, after this study, they have come up with a hypothesis that is actually not a mimic because there are a lot of features which are very similar to the sporadic ANA with few exceptions. So it's actually a variant of ANA rather than mimic of ANA. So these are the 4 broad varieties of ANE. If you see the classical ANE followed by other viral infections is called the sporadic ANE, followed by DANE. DANE is dengue associated ANE. And the third one is we have seen a lot of these cases in the COVID pandemic. This is the COVID variant of ANE. And the final one, the familial ANE. I think everybody needs to know about this. It's called the genetic ANE or RAN-BP2 variant. You need to do a whole exome sequencing to document a likely pathogenic or a pathogenic variant in RAN-BP2 mutation. So what are the differences? So the sporadic ANE is typically seen in infants and children. That's why it's called ANEC, that is acute necrotizing encephalopathy of childhood. Whereas if you see Dane, COVID, and genetic ANE can happen in children as well as adults. We see systemic manifestations are very predominant in the first three, whereas the genetic variant does not have systemic manifestations. And in the sporadic and the Dane, you have a lot of thrombocytopenia and transaminitis when compared to SARS-CoV ANE, where you have a lot of coagulopathy, shock, and transaminitis. And if you see, as I said, Dane is a variant exception wherein the infection and immune system activation is happening simultaneously. That's why this is the only variant of ANE wherein you have pleocytosis happening. And also remember, on the MRI, SARS-CoV ANE and RAN-BP have specialized features apart from thalamic white matter brainstem involvement. They have involvement of medial temporal lobe, insula, and external capsule. Remember this external capsule. Whenever you have external capsule involvement or an insula involvement, think of genetic RAN-BP or genetic ANE. Why is it so important to diagnose that? You may have to be very careful in these patients because you have the 50% recurrence, because one event itself is very devastating, and a 50% recurrence is going to be a probable death statement. So we need to be very careful in these patients, avoid triggers of infection, vaccinate them appropriately, and prognosticate them accordingly. So this is I'm talking about. This is the putamen. The green structure is the putamen, and outside the putamen you have something called external capsule. The external capsule is typically involved in a case of RAN-BP2 ANE. A very similar and closer structure. So this is putamen. Outside the putamen you have something called external capsule, and outside that you have claustrum. So when claustrum is involved, and that is a sign of FIRES, that is febrile infection related epilepsy or status epilepticus. That's a different entity, but a very close structure. When you have claustrum involvement, it's FIRES. When you have external capsule involvement, that is RAN-BP2 ANE. So these are the major four players. We all know that there's a clear-cut evidence saying that a combination is more effective than monotherapy. The first line is going to be methylprednisolone, high dose for 3 to 5 days, that is pulse methylprednisolone, plus IVIG/Plex. And a tocilizumab can be an add-on when there's no response or you have a documented evidence of a high IL-6 in the CSF. So I won't go into the details of the mechanisms of these drugs. So there's a newer technique wherein it's called the zipper technique or the zipper merge. So this concept came from the engineering of the road traffic of the Germany. So instead of, if there is a lane closure, instead of diverting the cars from the beginning of the road, you can actually continue the vehicles till the end and use all the lane space. So this basically saves the road space and also saves the time. So merging in the last moment, so utilizing the road as much as it can. So the same technique is used in the treatment, and this is called the zipper technique. So I'll try to explain. For example, in immune-mediated conditions, we tend to use plasma exchange, right? So we give 3 or 5 cycles of plasma exchange and then give IVIG. We cannot do vice versa because we can't start with IVIG and then give plasma exchange, because that's going to technically wash out all the IVIG. So if you want to give steroids and then plasma exchange, after finishing the cycles of plasma exchange, you can give IVIG. So there's a newer technique which says that we can alternate the sequence of plasma exchange with IVIG. So here we don't give the whole dose of IVIG, we give a small dose of IVIG, that is 0.4 gram per kg. And immediately after that, so why is this important? Because plasma exchange is going to clear off all the cytokines in the system, but IVIG is going to clear off it's going to neutralize the antibodies. So we can't wait for the 5 days and then give IVIG, because ANE is not going to give that much time. So IVIG, a small dose, again a next cycle of plasma exchange and next cycle of IVIG. So this is going to be alternating. This is called the zipper technique. So what is the rationale behind? So it's combining both the techniques and you have a better or synergistic action of both. So this is the traditional technique wherein you have plasma exchange alone if the patient improves, well and good, or you give IVIG alone, or you give plasma exchange followed by IVIG. And then to the newer concept, that is the zipper technique, wherein you have plasma exchange alternatively with IVIG, small dose IVIG, or there is something called modified zipper technique wherein you have longer cycles of plasma exchange with a bigger interval. So I won't go into the details. I think I'm not the correct person to talk into the details of that. I think intensivist will take care of this. So quickly about the takeaway messages. The first thing, dengue encephalitis is accounting for 5% of all cases of dengue cases, and sometimes it can go up to 21% cases in India. So the diagnostic criteria is Mitsubishi criteria of ANE. The diagnostic criteria says that you have acute encephalopathy, typical MRI features, exclusion of mimics like mitochondrial cytopathy, flaviviruses, and other organic acidemias which have bilateral thalamic involvement, there shouldn't be any pleocytosis. There should be elevated transaminases and normal serum ammonia. This is the Mitsubishi criteria of ANE. And exclusion of mimics, I was talking about other flaviviruses, strays, mitochondrial organic acidemias, and drug toxicity. I had one case wherein there was toxicity with metronidazole. The child had acute gastroenteritis followed by acute encephalopathy. It was misdiagnosed as ANE and it was given Plex and methylprednisolone high dose. But later on, it came out to be metronidazole toxicity because there are few features which differentiate ANE from metronidazole toxicity. Sometimes you need to consider other mimics which can have the same neurological signature on MRI. So ANE is not ordinary encephalitis. When thalami speak, do listen to them. Rush in the steroids plus IVIG slash Plex. Tocilizumab is just an add-on. It is not the replacement for all of these because tocilizumab is very precise medicine. It only acts on IL-6. We all know that there are other inflammatory mediators and other mechanisms working as well in ANE. And if the storm revisits, look to the genes, the hidden blueprints like RAMBP2, guarding secrets of recurrence and risk. In essence, bilateral thalamic flames are not mere shadows. They are the fire of ANE. Recognize, respond, and rescue.